therapies. So the first pharmacological therapies I want to highlight are mineralocorticoid receptor antagonists and the trials that are associated with them. Of course, we had the great news in 2024 that finerenone in the Fine Arts trial reduced the primary endpoint of cardiovascular death and total heart hospitalizations in HFpEF. So that was fantastic news. So going on, we've got some more trials in this area. One is called Redefine HF. And this goes beyond fine arts. Fine arts was mostly outpatients with some hospitalized patients. This is an exclusive trial in people with hospitalized HFpEF. So a very large trial, 5,200 patients with a primary endpoint of cardiovascular death or heart failure event. So really exciting trial. So in this area too, we've got trials of steroidal mineralocorticoid receptor antagonists, in this case spironolactone. We've got two trials called SPIRIT, one in Europe and one between Sweden and America. Both similar trials. The SPIRIT in Europe is 1,300 patients. The SPIRIT in the US and Sweden is 3,200 patients, both with similar primary endpoints, so total heart hospitalizations and cardiovascular deaths. So beyond antagonism of the mineralocorticoid receptor, we have other strategies here to block the mechanism of aldosterone. And here we have aldosterone synthase inhibitors. So this actually, instead of blocking the receptor, blocks the synthesis of aldosterone, which has got many theoretical and practical benefits. So here we have the ASIs, as we call them, the aldosterone synthase inhibitors, examples of which are baxdrostat and vicadrostat. The largest trial here in this area of HFpEF is EASY-HF. This is the HFpEF version of this trial, with 6,000 people with HFpEF randomized to vicadrostat and empagliflozin against empagliflozin by itself. So again, very large trial, fascinating, looking forward to seeing these results. So moving away from aldosterone and MRAs, I want to concentrate on inflammation in HFpEF. I've heard for over 20 years that inflammation drives HFpEF. We have comorbidities driving macrovascular and microvascular disease, particularly in the heart, but other organs as well, resulting in end organ dysfunction, such as myocardial dysfunction with things like fibrosis and apoptosis and hypertrophy. So we've now learned from people like Paul Ridker of the central role of the NLRP3 inflammasome, and particularly we've narrowed down now to the role of interleukin-6 in cardiovascular disease, but also in HFpEF. And we've seen a lot of data now showing that IL-6 levels, if they're high, are associated with bad outcomes in terms of hospitalizations and cardiovascular death, as well as worse functional status. So this looks like a good target to inhibit in HFpEF. We've seen that there is potential to modify clinical events to reduce heart failure hospitalizations by anti-inflammatory therapies in the CANTOS trial. The CANTOS trial was not a heart failure trial. It was a trial of people with myocardial infarction and systemic inflammation randomized to canakinumab, the IL-1 beta monoclonal, against placebo. And we did see a reduction in heart failure hospitalizations. It wasn't huge, but we did see a reduction. Those who achieved greater reduction in inflammation measured by CRP had a greater treatment effect. So this has led to the HERMES trial. So HERMES is a trial of ziltivekimab, so an interleukin-6 ligand antibody against placebo in a typical HFpEF with systemic inflammation population. So these people have elevated CRPs greater than 2, as well as ejection fractions greater than 40%. So a large outcome trial of 5,600 people in this space. We've also got a functional outcome trial, which is the little sister of HERMES, called ATHENA, a smaller trial of 680 patients, again, ziltivekimab against placebo, but this time looking at the Kansas City Cardiomyopathy Questionnaire clinical summary score. So moving on now to GLP-1 based or weight loss pharmacological therapies in HFpEF. Very exciting area. We all know we've seen the STEP HFpEF program of 1,100 patients with obesity-related HFpEF showing improvements in quality of life, reductions in body weight, as well as reductions in CRP and NT-proBNP, but also a reduction in clinical events, albeit with a small number of events. A similar trial called the Summit trial with tirzepatide, this time a GLP-1 receptor agonist married to a GIP agonist against placebo, showing similar results to HFpEF, this time more clinical events, showing a reduction in heart failure event, cardiovascular death, or oral diuretic intensification. So these two trials have really excited the whole area of HFpEF. And we've now seen an explosion of these therapies, over 200 different weight loss pharmacological therapies under development. And here are some of the classic examples of drugs under development and drugs of interest for potential HFpEF trials. Lots of them have a GLP-1 receptor agonist basis, but also married to other things like GIP agonism or antagonism or glucagon agonism or amylin agonism. But there's lots of different drugs in this territory. So for the new trials that are being designed and we're looking forward to the announcement of, we're looking for trials in HFpEF with weight loss pharmacology that show a reduction in heart failure events or cardiovascular death, so in large trials showing convincing treatment effects. We're going to see the effect of weight loss effects as well as weight loss independent effects, and also effects in body composition, adipose tissue against skeletal muscle. We're also really keen to see trials in non-obese HFpEF as well with these agents, and a lot of us think these drugs are likely to be beneficial independent of their effects on weight. So now quickly to look at interventional therapies. We're going to look at just a few of these. First of all, in the atrial fibrillation subtype of HFpEF, we've got a large trial called CABA-HFpEF. Again, 1,500 patients randomized to ablation or no ablation with a proper clinical endpoint of cardiovascular death, stroke, or cardiovascular hospitalization. Now, looking at atrial septal devices, we've seen some promising trials before, but no positive trials. 2 ongoing trials in this area. One's Responder HF with a Corvea device, 700 patients with a composite of heart failure events and quality of life as the endpoint. Really robust sham-controlled trial. Also, a lay HF. This does not implant a device, but leaves an intra-atrial septal communication with the Alleviant system. Again, a similar primary endpoint of 500 patients. We need so many more randomized trial on HFpEF looking at these different subgroups of HFpEF, which are all fascinating. So to summarize, these are exciting times for HFpEF. We've got many ongoing and planned trials, and the future is very bright as we begin to understand HFpEF and focus our trials on the subgroups of people with HFpEF. Thank you for your attention, and I'm looking forward to the discussion.